Again, would like to welcome everyone to tonight's session on addressing gun violence and from physicians' perspective. This is a collaborative effort of subcommittees of American College of Physicians, Maryland chapters, Women in Medicine, Wellness, International Medical Graduates, and diversity groups. We have speakers, Dr. Andrew McGlone and Mr. Jared Frost, who will be sharing the points of view, and we hope that you will have questions. If you do, we'll have several minutes left at the end of the presentations for us to have discussions. But if you have immediate questions, please feel free to put them in the chat box. I will be monitoring it, and that way we won't miss your question or comments. So I'd like to go ahead and have Dr. Andrew McGlone to introduce himself and take over with his portion of presentations. Thank you so much for joining us today.
Hi, good evening, everyone. Thank you for that introduction. My name is Andrew McGlone. I am a family doc by training. I went to University of Maryland Medical School and did my residency there as well. From Baltimore originally, and I live and work down here in Annapolis, Maryland, where I've been here since about 2005. Presently, I'm the Executive Medical Director for Primary Care and Community Medicine for Luminis Health. And hopefully everyone can see my screen. And I will go ahead and get started. So we wanted to talk to everyone tonight about really a public health issue that is guns. There's really no debate anymore that firearm deaths are a problem in the United States of America. We're an extreme outlier amongst other similar countries. We sort of rank extremely high in firearms per capita. And then whereas amongst other countries, there does not appear to be a increase in population death rates by firearm per an increase in gun ownership. The United States, again, is an extreme outlier in compared to the rest of the world. When we think about gun deaths, mass shootings tend to capture most of the media attention and really are when you'll see most calls to action occur nationally. Most people can remember 1999, the Columbine shooting. I think was unique really in that it was occurred in a high school. That year there were a total of 44 lives lost and then 54 wounded. Jumping to 2012 was another sort of shocking moment in history where, if you remember Sandy Hook, where we had a significant loss of life in an elementary school. Again, that was just a percentage of the population that lost their lives to guns in mass shootings that year. I bring up 2018 because it was sort of a significant year in our community. The Capitol Gazette shooting occurred right in our backyard here where I work, where 5 members of our community lost their lives to a mass shooting. That was the second mass shooting in Maryland that year. And again, significant 80 people lost their lives, 66 wounded. This year again, I think it got on everyone's minds after a series of shootings, with specifically the Uvalde elementary school shooting, another significant loss of elementary school lives, and then followed rather closely by 5 people, medical professionals, losing their lives in the Tulsa shooting. So a lot starting to hit closer to home. To date, you can check these statistics, they're widely available. Currently, there's been 628 people who've lost their lives in mass shootings in 2022. These statistics, these images are really shocking to us. I think they hit us all personally Many people may have connections to a lot of these mass shootings. There's so many of them. It certainly prompts an emotional response from all of us about this. This is an immensely polarizing topic in the United States. And I would ask you just to bear with me during this presentation and just sort of open up your mind a little bit. So you may have a particular opinion about guns in this particular setting, but I want to sort of allow some space for us to think and sort of talk about this subject, and really again just kind of focus on, as clinicians, what are the key parts about the patients we care for, and how can we be successfully in this space in a productive way. Something I like to remind myself too, and again, you'll see a lot of vitriol and things thrown around when we talk about this, particularly in society. And if you're on one side of this or the other, the sort of the second you label someone on a particular side, you kind of oftentimes quickly negate their opinion without really getting a chance to understanding it. 2018, because of the Capitol Gazette shooting, launched sort of a process for my organization to really say, how can we best be involved? What can we contribute to the community as a healthcare system in this? And so one of my mentors in this situation, as we got underway, and I can share you with our story, what we did, he really said to me, you're going to have to talk to everyone. You're going to have to talk to gun owners, non-gun owners, really start to get people's opinion if you really want to shape something that will take hold. So I'll thank you for bearing with me on that. A couple just facts for us as we kind of get into this discussion for us to consider. It's really unmistakable that guns are just woven into the popular culture of America. Certainly in movies, popular references, guns are certainly everywhere. There are an estimated 393 million guns in America, which is outpaces the population of the United States. Gun ownership is guaranteed to citizens by the Second Amendment, and guns may often be a vital part of one's occupation, family traditions, or recreational life. I bring this up to just say that guns really aren't going anywhere in our society. I think that's the reality of it. And so I think it's an important thing to call out. Juxtaposing that to what's really happened, particularly in the last 3 years. In 2022 May, firearms overtook auto accidents as the leading cause of death in children. This is was published by the New England Journal. And at the same time as guns are everywhere, we really are going to face multiple reasons as clinicians that we're going to have to be compelled to really act from a sheer just sense of the impact on morbidity and mortality associated with firearms. Another fascinating thing that's happened in the last several years is that most of the mass shootings that were committed since 2018 have been committed by men under the age of 21, which is a unique sort of call out. Historically, that has not been the case. Overall firearm-related deaths continue to jump, as you'll see in this slide. I also just want to call out too that as healthcare workers, we are 5 times more likely to experience workplace violence than any other worker, and we comprise 73% of all non-fatal workplace injuries and illness requiring days away from work. So, we are sometimes too accustomed to threatening behavior from patients, and it's important to call out. And unlike some industries, like the airline industry, there's really no federal protection for us as healthcare workers. Obviously, the Tulsa shooting again just lays that a little bit bare. And I know many organizations have had to have significant series, lectures, et cetera, about us protecting ourselves, which again really becomes scary. Mass shootings are not necessarily a new phenomenon. They have existed. This slide is just interesting to consider, particularly when you start to talk about gun laws. and if they make differences or not. That sort of calls out the period where there was an assault weapons ban. There's a lot of debate about whether that was effective or not. But one of the most interesting sort of pieces about it there, if you look at it, there really wasn't a decline in mass shootings per se, but certainly there was a lot less deaths by mass shooting. And if you simply just think about it, if people can fire less shots per second and have to take time to reload, there is a statistical relationship to that phenomenon, which is usually less mortality. That said, mass shooting appear to be on the rise if you sort of look at this graph over the last decade. And so again, it's just really a significant thing. When you look at mortality by state, there's a lot of variation in terms of age-adjusted death rates. So you'll see some key differences. There in Maryland, we're about in the middle. We'll sort of talk about that specifically. But you'll just notice that there's some regional differences, et cetera, as pointed out by this slide. Just a quick other bit about Maryland. Maryland has a firearm death injury rate of about 13.5 per 100,000. It's just outside the top 10 leading cause of death. These numbers always go back a couple of years because they're pulled from CDC data. But it's not an insignificant amount, certainly compared to other conditions, cardiac disease, again, remaining the leading cause of death in Maryland. So in giving you all that information, I always think it's important to think about, well, what is our role specifically? We're not sort of criminologists. We certainly aren't policy experts. We fortunately have one to talk to us tonight. But our role is really clinicians, and we can approach a problem in the same way that we do always, which is that, is there data out there? If there is data, what is the data telling us? How can we use that data to have the biggest impact? And then really just thinking about it out loud, are we impacted as clinicians by the gun debate? Are we afraid to bring up certain topics? And if we are afraid to bring up certain topics with our patients, how does that truly impact our care for them? Certainly, we feel very comfortable telling children to wear seatbelts, but again, that's now been outpaced by gun deaths. So we should be very comfortable talking to kids and their families about firearms if you just follow my logic. I want to break down gun deaths sort of into some 4 broad categories, and I think this helps us sort of think about our impact. So there's 45,000 deaths by guns in 2020. Again, you see that's a jump from 37,000 in 2017, which is right around the time my organization started looking at this. However, when you actually break down the statistics, categorically, those categories are very different. So mass shootings account, even though again that they account for most of the news based on gun deaths. They're a very small percentage across the board. Suicide continues to be the number one cause of gun deaths, then followed by homicide, and then an unfortunate amount of accidental or unintentional deaths every year from guns. So again, thinking about that, clinically, we certainly know where highest value of our time can sort of be spent, and suicide really jumps out in that particular case. I don't want to skip over homicide. Maryland specifically has a unique problem that we have an extraordinarily high homicide rate per capita in our state. And there is a very significant racial disparity to this. So Black males have a significantly higher risk of dying by firearm in our state, that it well eclipses anywhere other group comparatively. I would love to tell you that I have any insight into solutions for this. There have been smatterings of research about it, a lot taking place locally, but certainly I can't really talk about it in Maryland without sort of calling our attention to that. Hopefully you guys will be hosting something in the future where we see how we can start to impact this just horrific racial disparity, but it certainly exists and sort of must be kind of kept in the light when we're talking about this. Shifting gears to a group, it certainly is something from a pediatric standpoint that gun safety and keeping kids safe really revolves around something simple, which is just safe gun storage. And you can find clips like this just, every year, all of the time. So obviously on the left side of the screen, we see a story of a toddler finding a gun and shooting himself. And this just happens again and again and again in our country. Amazingly, too, toddlers are also responsible for actually shooting and killing a lot of their family members. This also happens frequently if you see on the right hand side of the screen. And it's really sort of a maddening situation. And we think about all of our efforts in pediatrics in terms of that revolve around safety, swimming, avoiding chemicals, all the kinds of safety that we do. This one is really sort of something that continues to happen, and again, has really outpaced other causes of injury. And the message here is really simple. We should be very comfortable with telling family members, talking to them, are there guns in the home? Do the children have access to guns? Unintentional shootings account for 1.3% of gun deaths and a high percentage of injuries. Again, most of these individuals are young, and it's estimated about 4.3 million children live in homes where guns are stored unlocked and unloaded. I would encourage all of you to run an experiment, which is to, if you have any children in your life, grandchildren, children, nieces, nephews, ask them what they would do if they find a gun. So you can also simultaneously ask them what they will do if they catch on fire. Every kid I've ever talked to can tell you to stop, drop, and roll if they catch on fire. You will get an amazing variation in responses to what they should do if they find a gun. Stop, don't touch, run away, tell an adult is one thing, again, or stop, run, tell someone, are just easy sort of things, and you wish this was something that was taught in school. But obviously, again, the polarity of this has really limited a lot of just common sense things in our society. And again, hopefully that this will become the new stop, drop, and roll. I want to briefly touch on mass shootings. I think it's important, again, just because I think that sometimes we think that we have limited opportunities to impact this. And the majority of that is true. But there's some interesting studies that have identified 4 common factors in mass shootings. One is these individuals usually have early exposure to trauma and violence. 2, they reach an identifiable crisis, usually in the weeks or months before. Most will show significant behavioral changes. Sometimes these are identified by their families. Sometimes their families reach out for help. It's very likely that these patients can get on our radar screen in this time period. Maybe presenting to an ER, being brought to an ER, et cetera, or coming into our offices. They do study the actions of other shooters typically, and oftentimes they have the means to carry out their plans. Obviously, if they don't have access to a gun, it's going to be impossible to do that. 80% of school shooters obtain the gun from family members. So again, this is an important sort of call out, and we'll talk about that later because again, if we know someone is in crisis, keeping them away from guns or acting as a family to keep them away from guns, again, is very critical. And again, just to highlight that the interesting trend recently is that these mass shootings seem to be committed by men under the age of 21. When we talk about that, it's important to just remember how impulsive this group is. We all can remember this, from learning about adolescence. again, we're talking about a reckless group of individuals that can be more prone to violence. Typically, their leading cause of death is related to activities that are oftentimes impulsive, accidents, fights, reckless driving, etc. And it's critical to really point out here that we know that the prefrontal cortex, which again is something critical to controlling impulses and understanding the consequences of your action, does not typically develop until age 25. There's a lot of data that sort of supports that development. I can certainly attest to this. Being a male, I'm confident my prefrontal cortex didn't really come into 26, 27. So it's really something that's pretty significant. And it's interesting that, and this, this seemed like this was going to get some momentum coming out of the Uvalde shooting, that maybe they were going to raise the age of the purchase of rifles specifically. The AR-15 rifle, which is often used in a lot of mass shootings, sort of falls into some loopholes, which allows it to be used, even though it's not, and we can sort of talk about this later. Whereas handguns really are limited to people under the age of are excluded for the age of 21. So there are laws against handguns and for if you're under 21, but again, there's and with any gun law, there's constant loopholes that sort of allow individuals to obtain guns as well. So, but just to call out, I was sort of optimistic that there was some momentum. You certainly heard this, but again, there's a lot of medical data in the same way that alcohol is prohibited under the age of 21, et cetera, that sort of call attention to this fact that the male brain in this age range is really underdeveloped in the prefrontal cortex. Moving on to suicide, which again is the bulk of where we can have the biggest impact. It's estimated that 30 to 40% of homes will have guns in them. Approximately 82% of people who commit suicide will use the family gun. Unfortunately, guns are the most lethal way of attempting suicide, and with 80% or more being associated with successful suicide. And one of the shocking things, and we actually reviewed this with our team last week, that 45% of suicide victims often have an encounter with a medical provider within 1 month of their suicide. So oftentimes, almost 1 out of 2 will come under medical's care in that month. And again, just to mention that suicide by gun, again, is really the most lethal means. And it really eclipses really any other means of death. And just having an access to gun will triple the risk of suicide death. So the statistics here, again, are just really significantly alarming, that if we're identifying anyone who's at risk for suicide, we should be taking steps to really consider if they have access to guns. Just to call out suicide rates in Maryland, again, you're going to see a little bit of change in demographics here, with white males being the highest risk group for suicide. But again, followed by the other groups as you see here. So again, just to call attention to that. What's curious about suicide is that suicide has been really shown to be an impulsive behavior that's a response to an acute crisis. If you survive suicide, 90% of the time you will not go on to die from suicide. So usually it will be a one-time attempt, and most people don't go on to commit suicide again. I published data from 2 sort of studies here that are really interesting. The one on the left side of the screen really starts to talk about when people make a decision, when they have an impulse to commit suicide, how long does it take for them to act on it? So on the left side of the screen, you can see here that 24% said that I acted on it in under 5 minutes. These are obviously suicide survivors. 24% saying between 5 to 19 minutes. So again, almost 50% are from impulse to attempt are within 20 minutes. The second study on the right-hand side sort of duplicated this phenomenon as well, which showed that almost about 50% of people who attempt suicide go from impulse to action in under 10 minutes or less than 10 minutes. So again, it can be an impulsive act. And again, having access to the most fatal means in an impulsive moment is really obviously a significantly dangerous combination. Most of you, I'm sure, if you are involved in care, use some type of depression screening tools. The PHQ-9 is a very popular one that has obviously a suicidality question 9. The EPDS for postpartum screening has question 10, which addresses suicidality. One of the things that we did in our organization was that we sort of set a bar for suicidality. If you scored a certain number on these tests, or again, if you answered any of the potentially positives to these questions, we sort of triggered what we described as a harmless screening, which is just basically saying, prompting our providers to say, do you have access to a gun? Do you feel safe? Do you have access to a deadly weapon? And that really prompted our providers to start to have these discussions, because again, if we know someone is potentially suicidal, we need to separate them from the most lethal means. There's obviously a ton of suicidality screenings. You can really better assess how suicidal someone is. Certainly the Columbia Protocol, the CSSRS is a great tool. There's many out there. Maryland is one of the states that has extreme risk protective orders. We started to have these in 2018. And this is something where clinicians, and again, many other people can file on behalf of their patients. And this is something that goes before a court. And if the judge rules that, that the concern is accurate, they can have any gun removed from them for up to a year if it's really deemed that they're in crisis. So these are really powerful tools that we have to reach out and help patients, particularly patients that are really at extreme risk for a variety of reasons. Again, not just if they're suicidal, if they're deemed to be a potential threat. So again, and then obviously most recently, these types of laws came to light, and that many states did not have them. But this is something I've seen personally been involved in one time. I've certainly seen it used other times, and it can certainly be a life-saving tool. I've found that patient to be nothing but grateful, and certainly they're still alive today. Engaging families to help is really critical as well. So again, if you're identifying suicidal behavior, having these conversations with patients is very important. There's really a shocking study that I found that found that only about 1/3 of gun-owning parents whose children were displaying risks for self-harm, such as depression, had their guns stored, locked, and unloaded. So again, really a recipe for disaster if you have someone who is suicidal, having them have that access. So what can you do about it? And again, I would sort of stress that, again, regardless of your beliefs on guns, really becoming comfortable talking to patients about guns is really critical, again, because they are everywhere. They're in a significant amount of homes. And really the conversation can easily just focus about safety. It's a safe space for common ground. You can reach gun owners. The focus is on access, not ownership. And interestingly, one of the things I learned talking to gun owners is that oftentimes if you talk about gun violence specifically, it tends to be an offensive term or even a non-starter, whereas gun safety is often a key tenet of gun ownership, and it's really a quick in there. So sometimes the language we use, again, it's not always sort of obvious. We don't have to get into some of those details, but again, we want to make sure that we're reaching the patients. Certainly, preaching gun safety to people who do not own guns, certainly is not quite the audience we need to be reaching in these situations. My organization published a lot of patient-facing and provider-facing handouts about this to really help educate our teams about how to have these conversations. Our general recommendation is to say, I have a safety question for you. Do you have access to a gun? It's a quick, easy way to start that conversation. And again, the basic tenets there: guns should be stored unloaded, locked, away from sight, and separated for ammunition. Again, this is very consistent with what's out there and all of the gun safety messaging. Again, we encourage everyone to sort of talk about that, and I already talked about with kids. Now, most critical, I think it's also important to just recognize that there are going to be times in your patients' lives where it may be, again, important to bring this up. So again, if you have children or teens in the house, if you have someone who's cognitively impaired, again, people undergoing dementia, certainly, and this comes up, again, it always surprises me when we start to talk about families. We don't always think about saying, are there guns in the house when people start to have significant cognitive decline? Certainly, again, we know some people, unfortunately, are plagued with a more paranoid type of dementia. We see that. Again, it's important to have that conversation. Are there guns in the house? Let's get those locked up. Let's get those away. Obviously, if you have someone who's has an addiction issue in the house, again, these access to weapons can cause all kinds of problems, including, again, diversion. A lot of crimes are committed with weapons that are sort of stolen or sold for other things. So again, that's another way to keep firearms off the street. And again, suicide is obviously an obvious one. This is just another sort of view of that. This is some of our patient-facing information, again, talking to what we describe as high-risk situations. Certainly bringing up people with a history of violence, again, is another particular group that we don't always sort of think about in this conversation. This is just an example of some of the things that we've produced. Again, we teamed up, the state of Massachusetts had already done some great work, and we sort of followed their lead with their permission with developing a lot of these direct-to-patient type of information. So again, can be very helpful and really help us get patients to be a little bit safer if they do have guns in the home. So some final thoughts about this for everyone to sort of talk about. Again, you want to be super vigilant in identifying patients at risk or in crisis, and you're going to want to engage appropriate resources when possible. Most of us are, screening for depression in multiple times. You want to also consider asking them about access to guns, again, particularly if they have moderate or more severe depression, if they have a history of impulsive behavior, et cetera. And again, other just times too. You basically want to engage in those conversations about when to make guns safe or when to make guns less accessible. I've found, again, in my conversations with patients, most patients are just nothing but grateful that you're bringing this up. You're just wanting to keep them safe. You're not making it about a Second Amendment thing. You're really just making about, let's get these away for a bit. Is there a place we can put them? Can we put them at a friend's house, a family member's house? Because again, you're not quite yourself just now. Again, we've got the ERPOs in Maryland. We can utilize them when they're indicated. Certainly as clinicians, we can support common sense gun legislation, like universal background checks. Across the board, these things, the majority of the population wants these type of laws passed, again, but there are obstacles to it. So certainly those are, again, very reasonable things for us to consider. There's a lot of scientific data supports raising the minimum age of purchasing. Certainly, as scientists and clinicians, we can support this. And then finally, I think there's something that I always find interesting is that, again, protecting ourselves, I think, is important. There is some effort underway by the AHA to promote legislation that would offer us similar protection that airplane and airport workers have, and that there's some federal protections that really don't allow for threatening behavior. So I think we're probably going to take questions after the next lecture. Is that correct? Or I can...
I think so. I
Okay.
think so. Thank you. And meanwhile, thank you so much, Dr. McGlone. And meanwhile, if anyone has comments or questions, feel free to post them in the chat box for us to review them later. Mr. Frost, floor is yours.
Great. Can everyone hear me? Great. I really want to thank you for having me. My name is Jared Frost, and I'm a senior associate in legislative affairs in ACP's Washington, D.C. office. I've been with the college for 9 years now, and prior to that, I worked on Capitol Hill as a legislative director in the office of a congressman. I am not a policy expert, but I am a healthcare lobbyist who's worked on a lot of the gun violence prevention advocacy work that the college has embarked upon over the last 5 to 7 years. And I will do my best to answer any questions or comments you'll have at the end. And I can certainly help put you in touch with someone within ACP if I can't answer those questions. So tonight, I just want to talk a little bit about ACP's policy, ACP's advocacy, the new Bipartisan Safer Communities Act, and the future of gun violence prevention advocacy, specifically maybe what the Maryland chapter can do in the future moving forward. Next slide, please. I'm going to start with our position paper that was released in 2018 called Reducing Firearm Injuries and Deaths in the United States. And it was actually an update of a 2014 position paper. And for more than 2 decades, ACP has recognized firearms violence as a public health issue and has advocated for the urgent need for meaningful gun violence prevention policy. And I'm just going to cover a few of those policies that this position paper has. First of all, is in keeping with this public health approach, is that physicians should become engaged in the issue of gun violence prevention, and such as continuing medical education programs and how to talk to patients about firearms, et cetera. Another component of our recommendations are universal background checks. So universal background check system, improving the National Instant Criminal Background Check system is also part of our policy recommendations. Next slide, please. Continuing our policy recommendations, these are just some of the policy recommendations we have. The position paper contains them all, of course, is closing the so-called boyfriend loophole was one of our policy recommendations. Essentially, current law up until the Bipartisan Safer Communities Act really didn't include other types of intimate partners and other living situations besides the spouse. And therefore, victims of domestic violence didn't have an avenue to prevent a gun sale for the NICS background check. It wouldn't qualify. You had trouble getting an ERPO or any other thing because you just didn't have an expansive enough definition of what, you have a stalker, or you could have some other type of abuse taking place. We also support an assault weapon ban or the restriction of large capacity magazines. And this goes to the fact of trying to contain the damage done in a mass shooting event. And that if you have a less powerful weapon or you have less ammunition to use, hopefully there'll be less injuries and deaths. Another component of our ACP's recommendations are extreme risk protection orders, which Dr. McGlone has talked about. And then lastly, straw purchases. This is simply someone who obtains firearms legally, but then sells or transfers them illegally. And that's an issue that we recommend would be addressed on the federal level. Next slide, please. So I'm going to switch to our advocacy now real quickly and what we've been doing for several years. In response to that 2018 position paper I talked about, the National Rifle Association, and some of you might remember this or recall this being in the media, the National Rifle Association attacked that position paper and told doctors to, quote, stay in their lane. But the response from the medical community was swift and overwhelmingly supportive of ACP's recommendations regarding gun violence prevention. Taking that momentum, ACP heeded the call from those physicians that supported ACP, and we organized a call to action. It was actually a second call to action that ACP has done over the last several years on gun violence prevention, supporting many of the recommendations I just talked about. And so in 2019, we organized this call to action with 6 major physician organizations, and then 35 other organizations joined us in making those, supporting our call to action. In addition to that, Leadership Day, which is our annual fly-in day, which I'm sure many of you have participated in, we started focusing on gun violence prevention as one of our priorities asking members of Congress to take action. So those are the types of things we started doing in the last several years on this issue. Next slide, please. I wanted to highlight an advocacy win, if you will. Starting about 3 years ago, Congress started funding one of the ACP policy recommendations in this area, which was actually gun violence prevention research. So for many decades, the federal government did not fund research in this area. So data collection, trying to find out the causes of gun violence, best methods for prevention, strategies, that was not funded at the federal level. Fortunately, through our efforts and the efforts of many other organizations, Congress finally started to fund this type of research, and they have put $25 million towards this type of research, $12.5 million in the CDC and $12.5 million in NIH. And for FY 2023, which actually starts on October 1st, we are requesting $60 million for this kind of research. Now, hopefully we will get it. We won't, but hopefully we'll get at least an increase over that 25 if we don't get the full 60 million. Next slide, please. In addition to all the advocacy efforts that were listed on the previous slides, ACP works closely in certain coalitions that other organizations also belong to. And 2 of those coalitions are the Giffords GVP Health Partners, and that's the Giffords organization. And if you are familiar with Gabby Giffords, the former Congresswoman, she has a wonderful organization that is, they are excellent advocates on gun violence prevention. And we have partnered with them in several state and local events in places like Florida and Colorado, where our own physician members have participated in talking about gun violence prevention and how clinicians can address the issue. Another coalition that ACP is part of is the Gvp Research Roundtable. This organization, or this coalition, I should say, advocates for increased funding for the research that I talked about earlier, but they also are really looking into what other areas need to be researched and sort of to help direct the federal government and what types of grants should go out for what types of research, and including expanding that type of research across the federal government. So instead of just having research grants coming out of NIH or CDC, we also have research being done at DOJ or the VA. Next slide, please. So this takes us forward to the Bipartisan Safer Communities Act, which was enacted at the end of June of this year and signed into law. So I just wanted to take a moment and talk about advocacy and how it's evolved. And again, this is not to pass along any judgment on which horrific mass shooting was more important or not important, but I've noticed this as an advocate and as someone who's engaged in this issue for a while, that after Sandy Hook, Newtown, even though the Manchin-Toomey bill wasn't successful in passing the Senate, it did provide a blueprint to build off of how to draft bipartisan gun violence prevention legislation. You go to Parkland, another horrific event, of course, and coming out of that, you saw a real shift or a pivot in advocacy. The victims, the children that were the victims of that horrific event really mobilized and really changed the paradigm of how advocacy took place on this issue, especially on Capitol Hill. I think it really gave a signal to politicians that did support gun violence prevention policy. It really gave them the signal that they could move forward more forcefully in advocating for new legislation. And then you come to Uvalde, which is the most recent horrific event. And I think the nation reached some sort of breaking point where they demanded that Congress act nationally. And then you had the advocacy that was in place from Parkland, and you had the blueprint on how to proceed legislatively from the Sandy Hook event. And the Bipartisan Safer Communities Act was passed, and it was passed on as the title says, it was passed on a bipartisan basis, which is quite unusual at this point. Next slide, please. So, if looking real quickly, this bill, which is now the law, has a lot of things in it, and it has a lot of money for mental health, especially for youth, but it has a lot of policies and provisions in there that ACP has advocated for. We talked about, Dr. McGlone talked about males under 21 committing mass shootings. There is something in here. It doesn't stop those individuals from obtaining firearms, but it does enhance the NICS background check into folks under 21 to see if they have anything in their juvenile history that would be a red flag that would prevent them from being able to purchase a firearm. It does things like making sure that a federally licensed, that someone who sells firearms is federally licensed. It gives money for community violence intervention, which is, I think, a newer area that might hold promise about trying to disrupt the gun violence in our communities. It closes that boyfriend loophole that was discussed earlier. It also increases penalties and gives law enforcement tools to address straw purchases. And then ERPOs, it creates a fund of money for states to use to get access to resources to implement their own ERPO programs for states that haven't yet implemented that, or for states that would like to need help carrying out their ERPO programs. And also, lastly, it does bolster the availability of mental health services that are of interest to ACP, including mental health training for primary care clinicians and something called the Primary Care and Training Enhancement Program. It also gives money to the 988 Suicide and Crisis Lifeline, which you might be familiar with, which I believe just went active in August. Next slide, please. So anyway, we're sort of at a pivot point here because we just had a major piece of legislation passed into law for the first time in decades regarding gun violence prevention. So we're going to have to follow that through because it's going to go through the regulatory process, and ACP is going to have to pay attention to what regulations come from the administration and weigh in on priorities that are important to us. In addition, in the next few weeks, ACP is going to be rolling out an updated Reducing Firearms-Related Injuries and Death Toolkit on the state health policy page. I put the link up there. It's available on our website now, but it's not updated to reflect the Bipartisan Safer Communities Act. And then as we're heading into the next Congress, which is the 118th Congress, ACP is going to have to formulate its priorities and strategy for gun violence prevention. I think a lot of that's really going to turn on the election and who ends up controlling Congress. But we'll have to wait and see. And then, we're going to have to just see where the gun violence prevention community coalesces and where the next steps are for implementing new policies. And we're going to have to see what works in the Bipartisan Safer Communities Act, and that's going to take some time too. Anyway, I'd be happy. I'm going to leave it there, and I'd be happy to answer your questions or hear your thoughts. So thank you.
Thank you very much, Mr. Frost, as well. I do see some comments and questions in the chat box. And if anyone else wants to join and comment on or ask question just via raising your hands, please go ahead. So first comment is Dr. Sparandero. The comments that Dr. McGlone offered some very constructive ideas for making a significant impact in reducing gun violence for our patients. And a focus on safety makes great sense in having conversation with patients, especially in a highly charged and emotional environment in the US on the issue of guns. The question is, I wondered how many physicians are currently talking with their patients about gun safety. How can we better train ourselves to be more confident and comfortable in talking with our patients? Thank you. Dr. McGlone, you're muted.
You're maybe on the 700th Zoom, I'll remember to unmute myself. So it's a great question. I think it's, again, it's one of those things that you certainly can learn. I would encourage people to start and to engage it. But we certainly can share what we have developed. Again, the state of Massachusetts actually led the way in this in terms of helping physicians have conversations. You can certainly Google that too. We can share that with you too. We sort of put out gun safety for providers, but I think it's just having that conversation in that safe space. The focus on safety really is a great way to do it. Just in the sense that do you wear your seatbelt? Pool safety. Again, down here close to the bay, we have swimming safety base, and we talk about these things just all the time. And it's really just kind of you feeling comfortable about it will really improve those conversations. But again, most people respond really well. And again, you're not talking about, it's careful not to talk about access, just talk about ownership. Just talk about access, not ownership. I said that backwards. So, you're not getting in debate about should someone have guns or et cetera. But again, just saying if they have them, that. And again, you can use that language of keeping it safe. I guess it also just contextually, obviously we'll have different conversations for pediatric patients, but certainly it's also just challenging. I think when we did this lecture a couple of years ago to our medical staff, a lot of people approached us and said, I have a old shotgun in the house. It's not locked up, and really, so just promoting locks, those kinds of things can be very, very helpful.
Thank you very much. The next question comes from comment and question from Dr. Tom Edmondson, who comments on the didactic portion of the presentation was superb, state of art and helpful. Thank you to all. And I like the suggestion to start the conversation with, I have a safety question. Do you have access to a gun? If a patient says they do, how should I respond?
I think it's, again, it's always in the context. If they're suicidal, typically in that situation, we'll involve family members right out of the gate. We'll have just a conversation just saying, hey, you're at a moment where, your brain isn't working. Oftentimes if they're admitting to suicidal ideation, those are scary thoughts to have. Usually it'll be met with relief, that's the only thing that I've seen in that situation. I've not been in a situation where, where we, obviously if someone is incredibly suicidal, you're going to, use either your county crisis hotline or get the patient to the emergency room. But it's critical to just engage family members. Most of the time, we've engaged family members with it. It's interesting. A lot of people, and just talking to people, a lot of people will have had family members commit suicide by gun often, and again, it's not something that's unusual. And so it really resonates. And again, you're just saying, make it less accessible. Is there a place you can store it where they can't access it? Is there a lock in the home? Is there something that we can do just to make it more challenging? We need to buy 10, 20 minutes, for most people, as the data shows there. So those conversations, again, I think are usually met well from my perspective. Like I said, I've only had to participate in an ERPO once. Again, that's it does work. It is helpful too. Hopefully that answers your question.
Thank you very much, Dr. McGlone. I do see some more comments from other physicians and doctors, and the question is, do you know if there's a data on PHQ-9 or other suicide screening guidelines being used in these patients? The research that you shared, that 45% of suicide attempting individuals have encountered physicians in the last months. So do we have any correlation with that, I suppose?
Yeah, I think hopefully I'll get to the what the question is being asked. I think in terms of, there certainly are great suicide suicidality screening tools that go beyond the PHQ-9. I think the PHQ-9 is just an introduction. Question 9 is pretty vague, you know what I mean? So obviously you can have a little bit of suicidal ideation in that particular instance, but not having active suicidal thoughts. That can really prompt a lot of conversation, sort of big clinical difference there. So a lot of times I would encourage people to pour into suicidality screens. I do like the Columbia protocol, which is the CSSRS, because it just easily flags people who are really high risk and where you may want to think of engaging emergency services. But in terms of, you know, I haven't seen a lot of long-term data in terms of, aside from just identifying depression, of, you know, how significant the PHQ-9 and depression screening is specific to suicide reduction. Obviously, it seems like obviously if we can treat more people, it correlates. But again, there really isn't any data, as Mr. Frost pointed out, that research has been incredibly limited and particularly when you talk about firearms. So it's only within the past couple of years that it's even been funded, and obviously funded at a small degree, and hopefully their effort to quadruple that will go into effect. But we certainly it seemed like a logical step to talk about access to guns in that suicidal ideation, or just moderately to depressed. But we just sort of set that mark based on what we felt was right. Unfortunately, there isn't data yet. We certainly hope that we would have data at some point to present, but obviously COVID sort of interrupted a lot of our plans in terms of studying it. Hopefully in my long-winded answer, I answered that question.
Thank you very much. Thank you so much, Dr. Christmas, for sharing the link. And thank you everyone for your comments and perspectives that you share on the chat box. Wonderful points. If no more questions.
There was a question in the chat. I just saw that.
Yeah, sure, please.
There is a really significant high rate of suicide amongst old men, particularly old white men. So it's just a high risk group to call out. And again, it was really a blind spot for me until recently to start to talk about, as we screen people for dementia and start to find more dementia, to talk about with families about getting the guns out of the house. So it's an important call out, and again, another population that we don't always think of being at risk. So that's a great call out from.
Thank you very much.
Can I ask a quick question, Narkis? I'm sorry, I didn't put it in the chat.
Oh, please go ahead, of course.
So right now, some Baltimore City residents may be aware that there's an issue that's come up with Hopkins hiring their own police department and having their own police department that's armed, and sort of like where their jurisdiction is and how they integrate with the Baltimore City Police Department, which no doubt has had a not fabulous interaction with the community, let's say. So as we think about personal safety in hospitals and crime that's been increasing, attacks on physicians have been increasing, what do we do about this? Do we advocate for more good guys with guns? Do we advocate against that because we know more guns in general are problematic? And I know it's a really nuanced, challenging question, but I wonder if either Mr. Frost or Dr. McGlone have any thoughts or reflections on that.
Thank you.
I can comment too that I certainly don't have a specific answer, but I can just say that I'm sort of a big advocate at our institution for really kind of reframing what we tolerate as clinicians. You know, we're really there to help. We know we're seeing people on often bad days, but I really think more zero tolerance to threats and sort of calling that out. I'm a big fan. I would love to have the same protections that airport workers have, et cetera. I think the more we can establish that that is not a place where behavior is like that. I think, again, it would be more protective of us. I think, as clinicians, and if you have gone through training, I think it's a good call out to say that you sometimes have to resist your instincts to just be helping everyone all the time, because you can put yourself at risk. I think it's, it's just sort of one of those situations. I'm not a fan of putting more guns into a situation. I certainly am not a security expert, but I think that, having more zero tolerance, that. And in terms of that, to speak of is just that, you can be federally prosecuted for making threats in airports, and on airplanes, I think is the big sort of difference between that. Whereas, we all have probably been threatened multiple times in our lives. And again, that usually doesn't lead to anything in particular for us. So, I know we've tolerated some pretty extreme behavior, most of us, in our training and or currently. So, I think it's fair for us to advocate for ourselves. Hopefully that answers your question a little bit, but yeah, that's scary to be in that situation.
I'll just try and add a little bit to that and talk about what ACPs, and I was debating whether to include this in my presentation, but I wanted to keep it as brief as possible. But I'm glad this subject came up. And so ACP has actually some newer policy in this area, and we've adopted in September of 2021, so it's about a year ago, policy on promoting policy standards for workplace violence prevention and management. So in that policy recognizes that harm violence causes, the harm that violence causes, and the need for additional research to better understand workplace violence and the most effective interventions. But the key is that we support legislative efforts to reduce and prevent instances of workplace violence and bolster workplace safety. And to that end, there is a bill in Congress that ACP supports. It's called the Workplace Violence Prevention for Healthcare and Social Services Workers Act, HR 1195. And it would require that OSHA come up with a workplace violence prevention standard for many different institutions. So that's something that ACP supports. So we have policy supporting that. Dr. McClone brings up that bill about the basically making healthcare workers, protected by federal law, and that's something where we're looking at. And it's a big step. It's also a simpler step than what I just talked about, because that would require, potentially thousands of institutions and workplaces to come up with a standard that then OSHA would have to review in some form. And that would take a lot of time and effort. So that's what we're working on. The pandemic has made everything that much worse. These issues have worsened. Our members have reported more anecdotal instances of being threatened and having aggressive patients. And so we need to do something to address the issue. So I hope that helps.
Thank you very much. Thank you all for your comments.
Oh, one more thing. We do have a advocacy toolkit on our state health policy website about workplace violence. So it's accessible on the website.
That's wonderful to know. Thank you. Again, thank you everyone for being here tonight. And I'll ask Dr. Christmas to give her comments and for tonight's events. Thank you.
Well, thank you all so much. I think this is a difficult topic to tackle. Many of us are nervous about bringing up the topic. Many of us are nervous about hosting a workshop on Zoom and how that's going to go. But it's patently obvious that gun violence impacts us as physicians personally, as well as the patients we're serving, the communities we live in, and we can no longer just be quiet about this issue. So while issues around legislating guns are usually sort of avoided in polite company, I'm really proud of the Maryland ACP. I'm proud of our committees. Thank you, Dr. Mugulaski, for hosting this tonight, for the committees that put this together for us tonight. I'm proud of our national chapter. I'm proud of what we're doing to try and move the needle in this really, really difficult area. And I'm proud of our chapter for taking this on directly to try and learn more about those efforts. I do want to put a little plug in for our chapter meeting, which is at the end of January. There are a lot of questions and discussion tonight about preventing suicide. And one of our outstanding speakers, Dr. Stephen Schoenfeld, is going to talk about suicide prevention there. I've heard him talk about this before. It's such an important issue, and it's getting worse. And so please come and join us for our chapter meeting if you're able to. The first day will be virtual. The second day is in person. I think Dr. Schoenfeld is in person on Saturday, but I don't have the schedule memorized. Join us at the chapter meeting if you can for that. Please join me in thanking Dr. Nargis, Dr. McGlone, Mr. Frost for a really mind-blowing, wonderful, jam-packed information session. I think everybody who joined felt like it was really helpful. Thank you all for joining, taking time out of your evenings. It's so inspiring that you were here to learn about this topic and to discuss it with us.
Thank you very much. Grateful to our chapter for providing opportunity for us. Thank you.